Our next quick review is on the subject of dementia, or major neurocognitive disorder. And remember, these are quick reviews, so we're just going over the high points. If you want more details, go to the longer dementia lecture. So patients with dementia have a gradual progression of multiple cognitive deficits. Of course, we immediately think of the amnesia when we think of dementia. And typically this involves a difficulty learning new information, and short-term memories are affected much more than long-term memories. Patients, remember, the whole brain is affected, so of course the amnesia, we think of the hippocampus and memory areas of the brain, but the whole brain is affected, including the language areas. So patients with dementia, if you listen to them talk, the vocabulary shrinks, and they frequently make paraphasic errors. Apraxia is very common. Remember, this is a motor problem with not weakness. It's not primary motor cortex, but it's the areas of the brain that store the motor programs for movement. All of the things we do every day, dressing, eating, driving, and so on. So patients with dementia have apraxia, and eventually, in a more moderate to advanced dementia, patients have difficulty dressing. They have difficulty eating. They just can't, manipulate the utensils well. If we want to check for apraxia on exam, we can ask the patient to do things like pretend you have a coin in your hand, show me how you would flip it, or show me how you would salute. And someone with apraxia may have difficulty doing those things. Agnosia refers to a problem with sensory integration. And so probably the most common would be the visual agnosias. So again, it's not due to visual loss. They can look at something and see it, but then the ability to get that information to the areas of the brain which can recognize the object becomes difficult. So patients have visual agnosia, and a typical one is prosopagnosia, which is a difficulty with recognizing faces. Remember, we talked about finger agnosia as part of Gerstmann's syndrome with a lesion in the left hemisphere angular gyrus, where patients have a difficulty in identifying their own fingers. That would be more typical for a stroke, but it's just another example of an agnosia. And executive functions are impaired. So I like to ask questions like, who pays the bills? And if the individual with memory loss stopped paying the bills 4 months ago, well, that would suggest, there's difficulty with planning and organizing, and bills getting paid twice or not getting paid at all, more likely, things like that. So first, mild cognitive impairment, very common. So these are at-risk patients because typically they're having memory or other cognitive dysfunction. And more than half of these patients will progress to what we can formally diagnose as Alzheimer's disease. This is more common if the presentation is of the amnestic form, where they're having memory loss, more so than other cognitive problems. And if patients are unchanged over a period of time, then we can just say this is normal aging. It doesn't reflect a neurodegenerative disease. So, of course, we want to do a workup in these patients. You'd like to find something that's treatable, fixable, so we'll always do metabolic testing to include B12 and thyroid function. If you do an MRI scan, you're looking to rule out anything structural, and if the patient has a lot of atrophy, especially hippocampal atrophy, then you know that the individual, that the manifestation does represent Alzheimer's disease. And so we'll do bedside memory testing, the mental status exam or the MOCA. We'll check for other things that might cause memory loss, like sleep apnea. You don't want to miss something treatable, or if the patient is on medications that cause memory loss. And I would say this is very common. So anticholinergic medications like tricyclic antidepressants, amitriptyline, nortriptyline. If a patient's on oxybutynin or a scopolamine patch for nausea, benztropine, remember an anticholinergic we use for the tremor of Parkinson's disease. So really, people over 65 should not be on these medications if at all possible. So remember, other clues would be parasympathetic involvement. So dry mouth, constipation, urinary retention often goes along with cognitive impairment when you block muscarinic receptors. Other medications, and we could make a much longer list here, but dopamine agonists. This is why we don't like to use ropinirole or pramipexole in patients with Parkinson's over 65 because it can cause memory loss. But someone may be on these for restless legs or other reasons. Certainly opioids or benzodiazepines impair cognitive function, neuroleptics, several of the anti-epileptic drugs. So you really have to go through the patient's medication list very carefully. And this is rewarding. If you identify this, you back off on that medication or change it, and then their cognitive function improves. Now, Alzheimer's as a kind of a rough guide, 1% at age 60, and it doubles every 5 years thereafter. So again, you should not be diagnosing a lot of Alzheimer's disease in people under the age of 65. Remember, the hippocampus is affected, so of course that gives short-term memory loss, but also the hippocampus is important for, it's the GPS center of the brain. So patients get lost easily. The nucleus basalis of Maynard produces acetylcholine projections up to the cerebral cortex, so if that's involved, as it is in Alzheimer's, that contributes to the cognitive dysfunction. And as we'll discuss later, when you enhance acetylcholine levels in the brain, that can help a little bit restore memory function. So most cases are sporadic. If you have 2 or more first-degree relatives, there is an increased risk. And kind of the big picture is that there is more of this amyloid beta protein. And so remember that the amyloid precursor protein, there's nothing wrong with this. We need this. It's present at normal synapses. It's not clear entirely its role, but it seems to be important for healthy synapses. But this is why patients with trisomy 21, because the gene for this is on chromosome 21. So if you have trisomy 21, Down syndrome, that's why these patients almost always get Alzheimer's disease as they get older. So the problem is when the amyloid precursor protein gets broken down either by beta or gamma secretase, and this then can lead to the amyloid beta protein. Okay, and remember this is what contributes to the amyloid or senile plaques, which are seen outside of the neurons. What appears to be really harmful are when these amyloid beta proteins aggregate together. And this is highly destructive. And sort of in parallel with this, we have tau aggregation. So tau is the microtubular associated protein, which again is important in normal function, stabilizes microtubules. But when this gets hyperphosphorylated, which happens kind of in this cascade, then it kind of clumps up inside the cytoplasm and impairs neuronal function. Okay, so remember we have neurofibrillary tangles here in the cytoplasm, and we can see these will extend throughout the axon as well. And the amyloid or senile plaques are extracellular. So you need to be able to recognize here on a brain biopsy or autopsy amyloid and the neurofibrillary tangles, which we can see outline this neuron here. All right, so here we have the amyloid precursor protein. Here is the amyloid beta protein, and you can see there are enzymes, beta, gamma, alpha, and gamma secretase. So if we have alpha cleavage, then notice that breaks up the amyloid beta protein, and so this is then not going to be a toxic form of amyloid. But if we instead here, let's say we start with beta cleavage, so we get rid of that amyloid precursor protein, and then we get gamma cleavage, well now we have the abnormal A-beta peptide here, which can aggregate, and again these aggregates are what are highly toxic. Okay, so we're going to find these amyloid plaques, and again in parallel with that we have this tau phosphorylation, and this makes up our neurofibrillary tangles. Okay, so very practical here, especially I've decided not to go over in our quick review all of the early onset genetic lesions because I think that's probably not high yield, but you should know about apolipoprotein. So remember there are 3 major isoforms. What you want to have is ApoE3. Okay, so this is seen in about 80% of individuals and is actually protective for Alzheimer's disease. You don't want to have ApoE2, that's associated with vascular disease, But ApoE4 is what is highly associated with the development of Alzheimer's disease. And so many people now get this tested. You have 23andMe and other commercially available genetics testing, and you can find out which of these that you have. If you have two E4 alleles, then roughly you have an 8 to 12 times risk of developing Alzheimer's by the age of 75. So it's a risk. It's not a certainty, but patients will come in often showing you their report and wanting to know what it means. Increasingly, epigenetic factors, especially anything that is of a vascular nature, just like stroke. So I won't go through these, but just all the things we think of as risk factors for stroke are also risk factors for the development of Alzheimer's disease, including most recently the finding that secondhand smoke, air pollution, and even pesticides are risk factors for Alzheimer's disease. So diagnosis, of course, we're going to make this clinically, but an MRI scan, you'll find generalized atrophy, and especially you want to do a careful look at the hippocampus. We don't do these routinely outside of a clinical study, but we can do PET or SPECT scans, and what we look for here is hypometabolism in the temporal parietal areas of the brain. So here's kind of a healthy brain in an older individual, not too much atrophy, but obviously here in Alzheimer's, very prominent. Look at the sulci here, the areas around the falx cerebri, much larger than they should be because of atrophy. And so if we can do a coronal section here of the temporal lobe, and here's a healthy looking hippocampus, which we can see over here, and notice that in this patient with Alzheimer's, the temporal horn of the lateral ventricle is much larger than it should be. It's really small over here. So this reflects that not much of the hippocampus is left, and so this would really be diagnostic of someone with Alzheimer's disease. Here's another look at here. The white areas are the lateral ventricles. So you can see here's a little bit of the temporal horn. There's the hippocampus. And so here we can see the temporal horn of the lateral ventricle is bigger than it should be because of hippocampal atrophy. Okay, and again, if we were to do a PET study, in blue here we see the hypometabolism in the temporal parietal region. And I don't think you'll be asked about amyloid imaging on PET, but this would really be a game changer if this is commercially available. And now we can actually see here in red the amyloid and would make diagnosis much easier. So treatment, we have 3 acetylcholinesterase inhibitors that are routinely used. I think boards will ask you about donepezil. That's the generic that you need to know. Rivastigmine is also frequently used, galantamine. There really isn't a lot of difference between these in terms of their clinical benefit, but remember they enhance acetylcholine through central inactivation of acetylcholinesterase. So remember that peripheral inactivation is what we're trying to accomplish with pyridostigmine for myasthenia gravis. But in Alzheimer's, we want to increase central acetylcholine. And so there's a mild benefit. There is some action in terms of peripheral inhibition of acetylcholinesterase, so that can lead to excessive stimulation of the GI tract, just like with pyridostigmine, and so we can get stomach cramps, diarrhea, and other GI symptoms. In a more moderate to advanced case, Momentine is indicated. This both probably blocks release of glutamate and also as an NMDA receptor antagonist. Okay, so we wouldn't use this in the early stages. And then just remember that a moderate to advanced patient with Alzheimer's frequently has depression, psychosis, so we want to be, in tune and treat that if we're seeing symptoms of that. Okay, multi-infarct dementia is probably the second most common cause, and unlike Alzheimer's, these patients are going to have focal findings typically on their exam from their strokes, and they get worse with each stroke, so it has more of a stepwise decline than Alzheimer's, where every few months is worse than the last. Now, I've usually emphasized that these are cortical strokes, but it is being recognized increasingly that frequent subcortical strokes also contribute to multi-infarct dementia. Okay, so they get worse with each stroke. You look for focal deficits. Now, remember that vascular risk factors are associated with an increased risk of Alzheimer's disease. And so therefore, because, obviously multi-infarct dementia is due to a vasculopath patient as well, frequently at autopsy, we will find a mixed dementia where the patient both has Alzheimer's and multiple infarcts. So these first two often coexist together. Okay, so here's a patient that has a PCA stroke, bilateral ACA stroke, here's an MCA stroke, so several cortical strokes, and obviously these patients, it's going to have a visual field deficit, leg weakness, symptoms of an MCA stroke like an aphasia, and so they're going to have lots of focal findings. And here's a patient with a bunch of subcortical strokes, and a lot of these may be asymptomatic. Okay, so sometimes we do an MRI scan and we're surprised how much ischemia, microvascular disease is present in a patient who may not have as much focal findings as you would suspect. Now remember, if you have lots of subcortical strokes and you knock out the cortical bulbar tract, that leads to pseudobulbar palsy. And so we've been through all of these now in our quick reviews so far. So multi-infarct dementia is pseudobulbar palsy in a patient who has had lots of strokes. If a patient has PSP and MSA, they're going to look Parkinsonian. And remember, PSP, you've got the vertical eye movement problem. Patients with multisystem atrophy have orthostasis. ALS, of course, is a motor neuron disease, so the cortical bulbar tract degenerates, Wallerian degeneration. And these patients will have mainly weakness with upper and lower motor neuron findings. And multiple sclerosis would be an example of demyelination of the cortical bulbar tract. So we think of a younger patient with optic neuritis and other complaints. And if they have lots and lots of subcortical demyelination, they'll have pseudobulbar palsy. All right, next, diffuse Lewy body dementia. The thing that usually stands out in these patients is the early hallucinations, which are usually visual and quite dramatic, often scary for the patient, calling 911 because they see someone outside. So early hallucinations are a tip-off. They have early dementia, and here I'm contrasting early in comparison to patients with Parkinson's. Remember, a third of patients with Parkinson's disease will have dementia, but the dementia occurs late. In diffuse Lewy body, we have dementia early, like within the first year of the onset of Parkinsonian symptoms. Okay, so a rule of thumb is early dementia with Parkinsonism, it's going to be diffuse Lewy body. And kind of along with the dementia, these patients have frequently dramatic fluctuation day to day. So there'll be a day where they just can't function, they can't remember anything, and then the next day they're pretty good. So that fluctuation is a lot different than what you would see, for example, with Alzheimer's. These patients almost always have REM behavior disorder. So remember, this is an alpha-synucleinopathy, and so this is seen in Parkinson's and in multisystem atrophy and in almost all patients with diffuse Lewy body. So they act out their dreams, often quite violently. And then finally, these patients have an extreme medication hypersensitivity to multiple medications, but especially anything that blocks dopamine. Okay, so a very dramatic effect to medications would go along with diffuse Lewy body. All right, so you look for Lewy bodies just like you look for in Parkinson's disease. Here's a Lewy body in the substantia nigra, but these are found throughout the brain, not just in the substantia nigra, hence the name, diffuse Lewy body. Okay, but they're otherwise similar to what you see in Parkinson's disease. And so in terms of the Parkinsonism, that's tricky to treat because they're already hallucinating, so if you give them levodopa, that can get worse. So you can give levodopa, you just have to be very careful, low dose, and some patients just can't tolerate those medications. Remember, you don't want to give a traditional neuroleptic that blocks dopamine because they're Parkinsonian. And so usually what we'll start first is actually an acetylcholinesterase inhibitor like donepezil, or rivastigmine is probably used more often because there's just it's been studied a bit more. And so this can help with the memory and even with some of the sort of behavioral aspects. And if you need to use a neuroleptic, use one that doesn't have much effect on dopamine, like quetiapine. You don't want to make their Parkinson's worse. Now, thymine deficiency, we've talked about Wernicke's encephalopathy, which, remember, is a patient that doesn't have to be an alcoholic, but it's someone who's thymine deficient. But they don't usually have symptoms of it until they're given IV glucose. Okay, and then they develop the triad with an ophthalmoplegia, so severe eye movement problem, they become confused, and they develop this truncal gait ataxia. And so we usually see this in patients who are in the hospital, emergency room, or admitted that are given IV glucose without thiamine. So you need to recognize that triad. Now, untreated thymine deficiency can lead to the dementia syndrome, Korsakov syndrome. Because if you give someone thiamine replacement who has Wernicke's, the eye movements come back to normal within hours, and if you recognize it early, the confusion and other symptoms respond. Okay, but an untreated Wernicke's, or just someone who has a chronic thymine deficiency over years, can lead to Korsakov's syndrome or dementia. And so this is unique because, of course, anterograde amnesia, there's nothing unique about that. Every patient with Alzheimer's or other dementia is going to have difficulty learning information going forward from when their disease started. But in Korsakov syndrome, the retrograde amnesia is quite unique. And this means they have patches of information, big holes in their memory for years or decades prior to the onset of the memory loss. And so what these patients do then when you talk with them is that they will fill in those patches with invented memories, and that is known as confabulation. So they're not malingering, but they're just filling in the gaps with invented memories, and so you get a different story typically every time you ask the patient about where they grew up and things about their remote past. So like most patients with dementia, like someone with Alzheimer's, they're alert, attentive, but they don't have insight into this. Okay, and that's actually true for most dementia syndromes. Like Alzheimer's, most patients have not that much insight. It's family members who are really aware and concerned. And so the mammillary bodies here, which remember are part of PAPE circuit, important for memory, the mammillary bodies send this information that they receive from the hippocampus up to the thalamus and then up to the cingulate gyrus. And so here are the mammillary bodies on this MRI. We can see this hyperintensity here. And so if you do an MRI in someone with Wernicke's, you're looking for signal changes in the mammillary bodies. And this can occur in other areas. It can occur down here in the kind of periaqueductal. But for boards, certainly mammillary bodies would be the classic location of the lesion. Normal pressure hydrocephalus, there probably isn't a single step 1 or step 2 board exam that doesn't ask this, which is kind of sad, honestly, because this is really uncommon, and the triad is the most non-specific triad you could come up with. All right, so patients with Alzheimer's, in a more end stage, their walking is impacted, and gait instability is just common in the elderly. Dementia, of course, urinary incontinence. So it's a very non-specific triad, but you will be asked this on board, so you just have to be able to recognize it. So it usually starts with a gait problem, and we call this a gait apraxia because it's not weakness. The motor exam of the legs in a chair or in bed is normal. They have normal strength and reflexes and all of that. But when they stand up to walk, the motor program for walking is impaired. And so they just kind of have a hard time getting started walking. So it starts with that, and then they have memory loss. And actually, the urinary incontinence is frequently not seen in normal pressure hydrocephalus in the real world, but it's always going to be part of a board scenario. Okay, and they can have some Parkinsonian features as well. So what we look for in normal pressure hydrocephalus, you want that story to fit, and when you do your scan, you see big ventricles, but notice no atrophy. Okay, so we do a lumbar puncture with placebo, and then we want to see does the patient improve when we do a high volume CSF tap. Okay, so why are the legs affected? Why is the bowel and bladder affected, or urinary incontinence mainly? So here's the paracentral lobule back here. And so remember, this is motor and sensory cortex for the leg, the bladder, and this program, the contribution to the cortical spinal tract, these fibers need to loop around like this all the way down. And so if we have enlarged ventricles, it kind of stretches the fibers from this location. Okay, so what is normal pressure hydrocephalus? Typically, or I should say, someone who is thought to have normal pressure hydrocephalus because their ventricles are big, which of course happens just with aging, so from atrophy. Almost always when we're referred patients that are thought to have normal pressure hydrocephalus, it instead represents early neurodegenerative disease. So the patient has Alzheimer's, they have PSP, or one of the other conditions we've talked about here in this lecture, not normal pressure hydrocephalus. Jakob-Creutzfeldt disease starts a little earlier than Alzheimer's, so around age 60 would be most typical. And there's a triad here. So first is a rapidly progressive dementia. So most of these patients die within 6 months. Much faster than the other dementia syndromes we've talked about. They usually have these myoclonic jerks, which are stimulus induced. So if you go into the room, you make a loud noise, the patient has an excessive jerk in response to that. And cerebellar pathways are affected, so these patients usually have ataxia. All right, so prions, we all have prions. All right, but we want to have normal prions, obviously, which the role of prions is not entirely well understood. But what happens is the abnormal version here, usually called the scrapie prion proteins, after the prion disease that affects sheep, is seen here in red. And when that happens, what happens is we have the normal prion combining with the abnormal prion, and then all of the normal prions develop the abnormal folding. And so they destroy the neuron, and then they move on to the next neuron, and this kind of escalates in an exponential response, sort of reaction. And so this is called a spongiform encephalopathy because the dropout of neurons is so rapid, and if we look at the brain on autopsy, it just has this kind of spongiform appearance. So to diagnose this, there are several things we can do. If we do an EEG, we get these periodic sharp wave complexes. More helpful and specific is if we do a lumbar puncture, and boards still will probably ask you about the 1433 protein, but the newer test, which is really sensitive and specific, is the RT quick test. Okay, so this uses recombinant prion protein, and it gets converted into the abnormal or the scrapie form here into amyloid. So this is a great and a relatively quick test. If we do an MRI scan, sometimes we'll see some signal changes here outlining the putamen and the caudate, so in the basal ganglia. Okay, that probably reflects the abnormal movements, the myoclonus. Okay, and even more specific finding would be this cortical ribboning here. If we see that in someone with rapidly progressive dementia, they have Jakob-Creutzfeldt disease. Okay, and I mentioned it's a spongiform encephalopathy, and so kind of these little vacuole spaces here in the brain is what we'd see at autopsy. All right, so most Jakob-Creutzfeldt is sporadic, up to 95%. That's only cases of Jakob-Creutzfeldt I've ever seen are sporadic. There's a rare familial form due to a mutation of the gene that makes prions. Iatrogenic is very uncommon now, but has been related to contaminated harvested human brain products like growth hormones or dural grafts, and rarely corneal transplants or giving IVIG. But there haven't been reported cases of that in a very long time. And so people are concerned about the variant form of Jakob-Creutzfeldt disease, and so otherwise known as mad cow disease. And so, but there've really been, I think when I looked last year, there were less than 30 reported cases of this, all of them in England and France. There's not been a single patient who developed this in the United States, or there may have been someone that came from England and then developed it. I don't remember, but there is some concern because of the high percentage when they do lymph node biopsies of the British population. 1 in 2,000 have the abnormal scrapey form of the prion protein. So who knows if this is going to be more common in the future. And you won't be asked this, but it's just interesting that in the variant Jakob-Creutzfeldt disease, you get this pulvinar sign here. This is the pulvinar of the thalamus, sometimes called the hockey stick sign. Frontotemporal dementia, like Jakob-Creutzfeldt, has an earlier onset than Alzheimer's, so the mean age is 58. And so this affects, as the name indicates, the frontal and temporal regions of the brain, spares the motor and sensory cortex. So oftentimes this would be one that is misdiagnosed as Alzheimer's disease, but it presents really with more of a behavioral personality change than Alzheimer's, which is more of the amnestic presentation. If it begins in the language areas in the dominant hemisphere, then this presents as a progressive aphasia. It doesn't look like a stroke because it doesn't come on suddenly, but the patient is just having a gradually progressive aphasia. So about half present with the behavioral variant, and so the orbital frontal cortex, so the frontal lobe, is affected. So these patients have disinhibition. They're making inappropriate comments, often of a sexual nature. They just kind of lose a filter, and they get into fights with people easily. Oftentimes they're kind of edgy when you see these patients in clinic. The frontal poles of the frontal lobe are affected as well, and so that leads to a loss of empathy. And so you want to talk with family members about that, and they will just frequently tell you that they just don't seem like the same person. Something sad happened, and they just don't make a connection anymore. Hyperorality is common, again, a frontal lobish kind of a feature, and so usually it's a fixation on sweets, and there may be some weight gain along with that, and they may develop compulsive behaviors, doorknob checking or some hobby that they'll just fixate on in a compulsive manner. Now, up to 20% of patients may have motor neuron disease, and if you recall when we talked about ALS, we said that the most common genetic mutation is the C9orf72. And so these make up almost half of familial ALS and about 5 to 8% of sporadic ALS. And so this is an intersect between the motor neuron disease ALS and frontotemporal dementia. And so patients with frontotemporal dementia may have the same mutation, and therefore 20% may have motor neuron disease. Now, if you do an MRI scan, you'll look for focal atrophy of the frontal and temporal lobe. And here we can see at autopsy here a lot of frontal lobe atrophy. And classically, these are called knife-edged gyri. You can kind of see that these just look a little sharp because of the atrophy. And then you would look for Pick's bodies at autopsy. So there are several subtypes of frontotemporal lobe dementia. The most common is tau, followed by TDP, and this is the one that is associated with ALS. Now, very commonly, individuals that have depression, anxiety, will have memory complaints, and so we're often asked to separate, is this Alzheimer's or is this related to depression, anxiety? So a number of clues. Remember, Alzheimer's is very uncommon under the age of 65. So we're a little primed for this in younger individuals that are having memory complaints. But remember, there are conditions like Jakob-Creutzfeldt frontotemporal dementia that occur in a younger population. Patients with pseudodementia, the onset can be abrupt and often related to, they can tell you when it began, at someone's funeral. I had a couple patients tell me. Oftentimes, they'll have dramatic fluctuations where one day they're great, another day they're very poor. On examination, someone with Alzheimer's is really, they don't want to have their memory loss revealed. So they're going to cover that up as much as they can. They're going to emphasize their successes. Someone with pseudodementia tends to emphasize their failures and may not give good effort when you're doing cognitive testing. You're going to look for any signs of depression, if they're sad, teary, having personality changes. Unlike most of the dementias we've talked about where patients don't have insight, someone with pseudodementia is coming in to see you because they're concerned about their memory loss. Usually in Alzheimer's, it's the family members that are bringing them in because they're concerned about memory loss. And if we do more formal cognitive testing in these patients, their memory deficiencies are inconsistent. Okay, so you test one certain area of memory like attention or something like that, and on some aspects of the test they do great, and then later on they do very poorly. So that would be inconsistent. And just in general, the depression is incongruent with the memory loss. Now, two others that I will not go into because we'll cover these in a later lecture. HIV-related dementia. This is seen late and has a very poor prognosis, but it requires a big workup because you want to look for other treatable things like toxo, lymphoma, other structural things that can impair memory in someone who is HIV positive. And then I won't talk about Huntington's except to remind you here on a CT of the caudate atrophy and our triad of dementia, behavioral problems with choreiform movements, and a family history. Remember, this is trinucleotide repeat. But we went over this in the movement disorders lecture. Remember, later on, the choreiform movements merge more into a Parkinsonian dystonia type of movement disorder. All right, we'll stop there.